questions. Number one, can I go back to work? Number two, can I go to the gym? Number three, don't have that. So how do you answer them?
Yes, yes, espresso.
Yeah, so they never ask Tanya, it's always like, oh, let me talk to her. But in general, really, you got a guy now with a low EF, is it safe to go to the gym?
Is he training for the Raleigh Marathon, you know, if you're doing gentle cardio and not like pounding it out, I would think it's okay.
They always ask if I exercise, will that strengthen my heart? That's not true, right?
That is not true, yeah.
But
Yeah.
it helps the body
Adapt
adapt.
to a low EF, yeah, so you become more efficient, your ability to extract oxygen gets better, et cetera, yes. But he's got nuance at low EF, you wanna wait? So for example, our guy with a viral myocarditis, I think in that setting, you probably should wait a little bit, kind of, he's still potentially having the heart shoot up. And so we let that process kind of heal. But for somebody who's got a more chronic issue and probably has coronary disease, it's probably less of a big deal to wait that way.
Would you recommend cardiac rehab though, instead of just going to the gym?
Yeah, you could,
Who
because
knows?
heart failure, and he may or may not have gone before for his stint. So in general, I think there's two questions that you gotta kind of ask and answer. What's the energy cost of what they wanna do? And then number two, can they safely exercise at that level? So we saw this 88-year-old lady today, what do? Oh, I do everything I wanna do, but then when you start pushing her, she does absolutely nothing, right? She has somebody that comes in every day. Her granddaughter brings her groceries. She does nothing. She just sits at the house. Her only outside of the house is to go to doctor's appointments. So for her, saying you can go to the gym, you have no idea if you can tolerate that activity or not. And so you gotta get a feel for that. So similarly for a job, right? Somebody who's got a desk job versus somebody who is, building houses, there's a difference from that aspect. So which then gets to the activity, A, or B, the gym. What are you gonna do at the gym, as you guys talked about? Are you training for a marathon or not? And then C, what about sex? And so you can get an idea about kind of activity based on what they can do, right? So what are their metabolic equivalents? And we'll get back to this in a bit. But our lady in the hospital right now, she's living at 1 Met, right? So if somebody wants to go and play basketball, and they're up here at kind of 5, 6 Met level, and they're only doing this, you really need to think about stressing them or something ahead of time just to sort that out a little bit from that standpoint. So the purpose of this was to really get into sex, and this is a depressing slide as I age, but it's there, right? So by the age of 70, about 30% of men have complete erectile dysfunction. 20% or so have minimal, and then the rest of them moderate. If you add cardiovascular risk factors to it, it really takes off, right? So once you have known CAD and you're a smoker, almost 100% of men have some component of erectile dysfunction. So this is big. They worry about it. They may not bring it up all the time, but you can see that the incidence is pretty high. And this is across all comers of age in this study. So of interest, sex can actually be at risk at times. And so this is a study where they interviewed patients after an MI and essentially said, what were you doing before you had your heart attack? To try to get an idea about activities, were you playing basketball, were you smoking, what was going on? So of these 1,700 patients, about half were active sexually in the prior year, and about a third had a known history of coronary disease walking in the door to their next MI for that group. And if you look, the relative risk of having an MI in the hour before, or of having, if you have sex within an hour, your relative risk goes up about 3-fold. So the risk is there, right? having sex increases your risk of coronary disease, and it really is for about the 2 hours prior. 3 hours out, it's less than normal, but in the last 2 hours, it's there. So there is some risk of saying, have some Viagra, still have sex, that you may kind of exacerbate some of this stuff. And it really doesn't matter, right? Whether they have a history of angina, no angina, a history of MI, or no MI, the relative risk of having sex doubles your risk of an MI for about 2 hours in the prior time, from an onset point of view. Additionally, dudes are really stupid, right? So they put halters on guys and said, go have sex and look to see what happens. And so 88 males, average age 52, with a 24-hour halter, with both kind of heart failure as well as coronary disease, with 80% having a previous MI, 17% angina. And so look what happens. So they looked at their heart rate during a stress test as well as during intercourse. And for those that had symptoms during exercise, they get their heart rate up to 113 and they stop. So what do they do during intercourse? They ignore it and they keep going and they go up to 122. So they're gonna do it, right? They're gonna ignore their symptoms that they may have and they're gonna keep pushing forward. If they have silent ischemia, no significant difference, actually stop a little bit earlier. If they have symptomatic or silent, but no ischemia during sex, heart rate's usually lower. But for the dudes who get chest pain during exercise, they're gonna ignore it, they're gonna keep going. So you've gotta worry about it from that standpoint. And lastly, this is a look at the LA earthquake. So big earthquake in LA, a lot of people died, bridges collapsed, all that kind of stuff. Look at the incidence of sudden death on the day of the earthquake compared to either before or after. And this supports my hypothesis that when the earth moves, people die. You get it? You get it? You get it? Come on. So again, 2 questions you gotta answer. What's the energy cost of the activity, and then can your patient safely do it at that level? So what's the energy involved in having sex? And this is the best study I've ever seen in my life, by far. So 10 couples that were healthy had a VO2 max of 54. And I think next week we're gonna talk about exercise stress testing and VO2, so you get an idea, but 54 is pretty good. Lance Armstrong at his peak was about 80. And most people kind of in the 25 to 43 range should be kind of in the 30s to 40s. These are healthy people. And so they monitored them. They monitored their heart rate and their oxygen consumption while they were having sex in a variety of different ways. It's an unbelievable study, right? They don't say how much they pay these people, but you wonder, depending on the person, if people paid to get in. So they looked at heart rate, and so partner stimulating them to orgasm, masturbating to orgasm, sex with the woman on top, sex with the man on top. What do you think would be the most kind of vigorous from a heart rate activity? And this is looking at it from the male perspective, right? So on top, heart rate gets up to 127 at the time of orgasm. And so it's hilarious, right? So baseline heart rate, foreplay, but 127 gives you an idea, right? So if you have somebody that can go up to 150, 160, and then have ischemia, they're probably gonna do okay during sex because it doesn't take that kind of heart rate. Additionally, they measured VO2. So to measure VO2, mouthpiece in, those clothes on, right? And again, you see, at the time of orgasm, and on top, his VO2 is up, let's say 12-ish or so. So heart failure guys that we think are ready for transplant have a VO2 kind of in the 12 to 14 range. So this is kind of peak exercise for a heart failure guy, is the amount of oxygen consumption it takes while you're having sex, to give you a feel at that. And you can kind of bring that out, right? So VO2 of 13 correlates to about 3.5 to 4 mets. And going back then to our table, what's the energy cost of the activity? 4 mets is the equivalent of self-propelled lawnmower, washing hands, or washing the floor, doing some painting, light yard work, et cetera, et cetera. So if your patient can do that, most likely they're safe for sex. If they get chest pain, you know, jogging, carrying 20 pounds at this kind of high 8, 9 mets, don't worry about it, they're not gonna get that high with sex. On the other hand, if you've got somebody who's this, I get dressed, I get in my car, I drive to work, I come home, I do nothing, you have no idea if they can handle kind of the 4 to 5 minute range, and so you kind of have to back. That's the person that you wanna think about stressing, from that standpoint. And so use this to get a feel for what they wanna do, because this is not only for sex, but it comes up all the time, right? Every TV show on Saturday morning that is not a cartoon is some new exercise equipment. And what do they always say on there? Before you do this, ask your doctor. So who in this class had a, how do you evaluate if it's okay to use such and such a machine? None of us did, right? But this is what you do. Can they tolerate the activity at that point? So what about Viagra? Is there a risk to Viagra in patients with CAD? What was Viagra initially studied for? No, angina. Yeah, it's an anti-anginal. So it is, and so it's a poor anti-anginal, but these guys in the study said, but I wanna stay on the drug because I'm now having an erection. So it's a side effect of an anginal study is where it really kind of came out. And so this is one just thing where they looked at, coronary artery blood flow, diameter, et cetera, et cetera. And as you can see here, you get more blood flow with sildenafil than you do at baseline in terms of coronary flow reserve. You don't get much in terms of vasodilation though with the coronary artery diameter, but you do get a little bit of blood flow there. So it's a poor anti-anginal med from that standpoint. The only side effect you really have to worry about is really headaches, right? 25% of headaches with the drug. And so you can throw in another joke there if you want to. Honey, I have a headache, let's have sex, right? But otherwise, no differences whatsoever, and no risk really in terms of MIs or anything that's in a small study that was done there. If you look at blood pressure, it's a fairly decent antihypertensive, right? So from baseline, at about 125 or so, systolic blood pressure will drop about 10 to 15 points. And so that I think is something you need to worry about for your baseline relatively hypotensive patient, that they use this and then they jump up out of bed, they may be lightheaded, they may take a fall. So I usually warn patients, be careful when you sit up because of that 15-point drop in blood pressure. With a lot of our guys at baseline kind of being that 100 to 110. One study kind of looking at the cardiovascular effects of this, they took patients and they got randomized to either sildenafil first or placebo first, and then they had a stress test, and then they came back and did the stress test again. So sildenafil stress, placebo stress, or vice versa, placebo stress, sildenafil stress. And looking at this, no differences really whatsoever in terms of reasons for stopping exercise on the stress test, or more importantly, no difference in the incidence of arrhythmias, or no incidence in the incidence of positive stress tests. So from that aspect, it seems to be safe, but it doesn't go the other way, right? You don't think this is an anti-anginal, somebody can do more. Really no significant differences whatsoever with the drug from that standpoint. And a small trial looking at open label, again, no difference in the incidence of big cardiovascular events with it. So it appears to be safe, not helpful, but not harmful. So what about heart failure? Not a lot of data, interestingly enough, in heart failure. 24 subjects looked at, again, peak VO2, et cetera, et cetera. Peak VO2 of interest goes up, right? So you get about a 3 mg per kg increase in VO2, which is significant from that standpoint, but everything else really doesn't change that much. Your wedge drops 18 to 17. PA systolic does drop 32 down to 25. So this is the pulmonary artery hypertension side of sildenafil, where it is a pulmonary vasodilator. This is an acute study. Chronically, you'll see sustained benefits from giving patients these drugs. And lastly, does Viagra improve survival? No data whatsoever to support that. but there's a ton of, studies that continue to come out, and I share with my wife on a daily basis. That if you look at mortality, continued sex is associated with increased 5-year survival. Men and women in their 60s to 90s, increased frequency of sex associated with decreased mortality. And this is kind of an interesting one in priests. Retrospectively, compared to age matched controls, they have increased mortality. So there may be something there, whether it be related to exercise or mental health or cardiovascular health or whatever else from that standpoint. So one study came out a while ago now looking at how to kind of look at this. And so they split patients up into low, medium, and high risk. Low risk patients, asymptomatic, and this is from a heart failure and a CAD standpoint. Controlled hypertension, mild stable angina, it's fine, they can go for it. High risk, on the other hand, out of control angina, uncontrolled hypertension, class 3, class 4 heart failure that's not controlled, recent MI, stroke, they said see a cardiologist and then wait until things are stabilized. And then the moderate group is more than 3 risk factors, stable angina, recent MI, and there they really said stress testing first. So in that group that you're worried about, you've got something to say, let's stress test you and see how you go. On that stress test, you're looking for kind of a 4 to 5 MET range. If they can hit that point before they have ischemia, they'll probably save down 6. That's all I got. We'll change the pace today. I should have waited till Valentine's for this. What'd you say? I'm sorry.
Sorry, I was a little more on the